Welcome to our video on counting items in the operating room. We will explore best practices for preventing retained surgical items, such as sponges, sharps, and instruments, to ensure the highest standards of patient safety. This video covers 6 essential modules, starting with the problem and the stakes, moving through why counts fail, the core count process, item-specific practices, communication roles, and finally, how to handle discrepancies. A retained surgical item is a serious preventable harm often called a, quote, never event. The surgical count serves as our critical frontline defense. Remember, this is a team effort where accountability is shared by everyone. While estimates of retained item rates vary, the impact of each event is devastating. Whether the risk is 1 in 100 or 1 in 5,000, the focus must remain on the fact that these errors are avoidable. To maintain safety, we must speak the same language. We define an unintentional retained foreign object as a mistake to be prevented, while intentional items are part of the surgical plan and must be documented and reconciled. Retained items cause significant harm. Soft goods like sponges can lead to infection or chronic pain, while hard items like clamps or needles may cause acute internal injury. This is why a count discrepancy must never be ignored. From a legal perspective, a retained item is an obvious error. Under the principle of the thing speaks for itself, liability for negligence is often presumed. Our protocols are designed to protect both the patient and the team. Professional accountability is real. Reports of these events are tracked, and consequences can include license suspension or exclusion from professional programs. Adherence to counting policy is vital for your professional practice. Moving into our second module, we will examine why counts fail. Understanding the root causes of these failures is essential for building a culture of safety. Common failure points include rushed counts, distractions during the process, or failing to separate items properly. Even a preliminary count that appears correct can be wrong, which is why visual and verbal verification is mandatory. Certain situations, such as emergency surgery, obesity, or long-duration procedures, carry higher risks. In these cases, it is crucial to slow down and ensure that every count is performed with extra precision and care. We must treat counting as a system, not just an individual task. While team members are personally accountable for their duties, the system must support them by minimizing power gradients and prioritizing safety over speed. Distractions often cluster at transition points, such as lunch relief or shift changes. These are the moments when our focus is most likely to slip, so we must be especially vigilant during these handoffs. In our third module, we will explore the core count process. Knowing exactly when, how, and what to count is the foundation of surgical safety. Finally, remember these 6 core principles. Always count with 2 people, make it audible and visible, follow a systematic sequence, minimize distractions, keep all items in the room, and always speak up if you suspect a discrepancy. There are 6 trigger points for performing a count. Note that the initial count should ideally occur before the patient enters the operating room, and anytime a discrepancy is suspected, you must perform a recount. The heart of safe counting is the triad of being audible, visible, and shared. Remember that any interruption to the counting process means you must restart. A partial recount is not a valid count. Coordinate your timing to protect the count. Avoid performing counts during critical phases like dissection or specimen handling. Always announce the start, ensure the surgeon acknowledges, and restart immediately if you are interrupted. Items fall into 4 main categories: soft goods, sharps, instruments, and miscellaneous items. The golden rule is simple. Everything added to the sterile field must be counted and recorded on the whiteboard immediately. The list of miscellaneous items is broad. If a small, disposable part could potentially be left in the wound, it must be included in your count. This includes items like Trocars, guide wires, and vascular inserts. Now we will move into our 4th module, focusing on item-specific best practices for each category to ensure consistency and precision. For soft goods, count in original package multiples. Running totals help keep the count accurate, and verifying the radio-opaque indicator is critical for safety. Never alter sponges unless intended, and never use a radio-opaque sponge as a dressing. Handling sponges on the field requires discipline. Keep counted sponges in a separate stack. When items are removed, open them before bagging to ensure nothing is hidden, and keep all items in the room until the final count is reconciled. For instruments, the count sheet is your source of truth. Always count in the same sequence. Remember that removable parts and fragments are countable items, so if something breaks, every piece must be accounted for. Sharps and needles are highly dangerous if retained. Use puncture-resistant counting boxes, placing only one needle in each slot. Keep these boxes in the room and include them in the final reconciliation process. Maintain strict discipline. Items must remain visible to the scrub personnel. Importantly, do not remove linen or trash containers from the OR until the final count is completed and fully reconciled. Moving into our fifth module, we will discuss communication, documentation, and handover processes, as counting is fundamentally a communication discipline. The OR whiteboard is your shared source of truth. Record counts immediately as they happen. Before starting, clear any stale data from previous cases to avoid confusion, and ensure both scrub and circulator agree on the recorded numbers. Documentation in the electronic health record is mandatory. You must document that counts were performed and whether they were correct. Also, ensure any therapeutic packing is noted and communicated clearly during handovers. When handing over mid-case, use the SBARR tool to ensure a complete and concise report. While temporary relief requires a verbal handover, permanent relief necessitates a full recount of all item categories. Closing and final counts are distinct, essential steps. The closing count starts during cavity closure, while the final count begins during skin closure. Remember, the count is not truly complete until every instrument used for closure is back in the scrub's hands. In our sixth module, we explore roles and responsibilities. Everyone in the room plays a part in ensuring an accurate count, as this is fundamentally a team-wide safety responsibility. The surgeon holds overall accountability. It is their responsibility to verbalize when items are packed in a cavity, acknowledge the start of the count, minimize noise, and perform a methodical wound exploration before closure. The circulating nurse is the custodian of the count record. From verifying a clean room at the start to maintaining an accurate whiteboard and documenting findings in the EHR, the circulator leads the reconciliation and escalates any discrepancies. The scrub person guards the sterile field. They verify item integrity before passing them up, keep sharps contained, and ensure every counted item is clearly visible to the circulator during the counting process. Anesthesia and radiology partners are critical to our safety net. Anesthesia manages throat packs and prevents rushed milestones, while the radiology technologist and radiologist work together to verify or rule out a suspected retained object. Next, we explore what to do when a count fails to reconcile. Having a clear, rehearsed response is itself a vital safety control that every team member must know. If a discrepancy arises, follow the protocol, notify the surgeon, pause the procedure, perform a recount, and conduct a physical search. If still missing, trigger a mandatory X-ray and ensure the team is aligned before resuming final closure. Remember, the X-ray is a net, not a guarantee. Ensure the image covers the full site and is read by a radiologist. However, the primary safeguard remains the surgeon's methodical manual and visual exploration of the wound. Exceptions occur in emergencies, but the safety standard does not drop. If a count is waived due to life-threatening instability, that decision must be documented, and an X-ray must still be performed before the patient leaves the room. Consider the lessons from past incidents. Failures often stem from a combination of factors: poor film quality, fatigue, staff changes, and distractions. These cases highlight why we rely on multiple redundant safety layers. Key lessons learned include: always explore the wound before closing, rely on radiology to interpret films, protect transition points like shift changes, and eliminate unnecessary distractions during the count. Technology like RF tagging, pocketed bags, and magnetic mats can support your efforts. While these tools make counting easier, they are intended to augment, not replace, the disciplined, manual counting of the surgical team. Safety is built into culture, not just rules. Establish a surgeon champion, gather monthly feedback on discrepancies, and review your policies after every near miss. A well-known, consistent policy is your strongest protection. In summary, remember to count at every trigger, perform audible and visible two-person counts, protect the count, and communicate clearly. Together, we can uphold the standard. No patient should leave the operating room with a retained item.